it's interesting. We've been talking a lot about the perspective of managing HIV, but along the lines of what you're talking about, with all of our advances in technology and pharmaceutical improvements, we're still at between 40 and 45,000 new cases of HIV every single year. And as a payer, you know, realizing that every year you're going to have 40 to 50,000 new entries into the consumer market of HIV products, that would, I think, is as much a concern at reducing the number of new infections. And that's in part due to getting more people on therapy, virologically suppressed. Treatment is prevention. But then along the lines of the other preventive efforts that you're adopting and you're seeing in New York.
But he's not denying payment. He's not saying I'm not going to pay for anybody. He just wants to be prudent. Is there a difference?
Well, maybe I am not seeing the big picture. I mean, are you seeing payers say no a lot?
So I'll tell you what's frustrating to me. If I have a single tablet regimen and I have a payer that says, we won't pay for that, but we'll pay for each one of the 3 components separately. And that's happened to me. And I've actually chosen one of the recommended for most patients drugs, and I've had a payer come back and say, we don't want you to give that one, we want you to give another one. And I've had good reason to not want to give the alternative one, or not. It's not even alternative. They're all on the same page, but they've done exactly that. And it's been very frustrating, where I felt that the best option for that patient was the particular choice.
And when you go back and say, based on X, Y, and Z, I want to do this, outside of just I like it or compliance, do they still push back?
It's a challenge.
Okay.
You know, some do. Some say we'll only give you the one that you want if they fail the other one. But in that case, that's not an indication. You wouldn't sequence somebody from one to another in the setting of failure. It wouldn't be appropriate.
Well, that would be a step therapy.
Right.
Right.
And that wouldn't have been appropriate in that particular scenario. So I'm a bit sensitive to that because it's frustrating. I've experienced that frustration.
So that's some of your cynicism. When he says we're going to pay for everything and you go, whoa, wait a minute. You've seen the other side.
And again, I'll go back. I think the DHHS guidelines are good. And I think if you would, you know, because that really, I can say 90% of my patients are treated with medicines I can count on one hand. And I think that is very much a part of the DHHS guidelines. But even then, the decisions I make are not necessarily driven by cost, but what I think is, you know, drugs within each class that have proven themselves to be, have advantages over others. And I'll keep coming back to darunavir within the class of protease inhibitors because I think that's a very good example.
But is there a significant difference between good and good enough if there's a significant price difference?
I would challenge that. I think you have to look at the specific. I think it's hard to generalize. I would say within the protease inhibitor class, again, going to darunavir, I really would not go to an alternative to darunavir. I think that for almost everyone would be the preferred protease inhibitor. If it has advantages, you know, in other words, if it has a higher genetic barrier to resistance, if it has less toxicity, if it has less drug-drug interactions, those are the things that I would try to wrap my head around as you negotiate cost, as you choose something. And my concern is, as weaker drugs or drugs that don't have the advantages see the newer products that have the advantages come out, then they will say, aha, I'm going to go to Jeff and I'm going to cut my price so that I can still maintain my my market share. And that's where I have concern that as newer drugs are developed with improvements, that the older drugs will lower their price to get your attention.
I think we'd have to have conversations about specifics, looking at drugs and what is a clinically meaningful improvement versus a cost. So I think it's kind of a little bit unfair in this situation without looking at that level of specificity. But I think that's legitimate. As these new drugs come out and we say they're better, let's have a conversation about what clinically that means in terms of better. And then, but at the same time, don't dismiss cost.
Before we go, I think everybody should have an opportunity to give just some sort of bullet point as to what you'd like our viewers to really take away and to remember. So why don't we start with you, Dr. Dunn?
Well, I think it's awesome the progress we've made in the last decade or 20 years in terms of having better outcomes, better drugs. Patients are living quote unquote normal lives. No argument that we've made a lot of progress. I do think that there's still a huge opportunity for the different, to use your term, stakeholders, have a little bit of a different conversation. And I will just say I think payers are viewed, and sometimes rightfully so, but sometimes not fairly, that we do things strictly for cost. But I do think that we have an opportunity to bring a lot of things to the table around data management and care management and looking at helping manage the patient more holistically. But it's unfortunately, I still think it's a little bit of a antagonistic relationship. And I would, my hope would be that we're not just dismissive completely of costs, and we can have a conversation about doing the right thing for the patient, but hopefully doing it in a way that is sustainable for the people who are paying for insurance.
Dr. Fatehi.
So I think it's amazing that we've come this far with HIV. It's a manageable chronic condition. We have amazing drugs that work that can get individuals to undetectable levels. And if we can help drive adherence to maintain those undetectable levels, I think that would be great for all of us as a society.
Dr. Sension.
I see the advances as really being a win-win situation for patients. I look to where we were 20, 25 years ago and where we are today. And we really, even the debate around all the different recommended regimens and the different options, they all represent easier to administer, better tolerated, simpler regimens that affect higher rates of virologic suppression.
I don't often give my own opinion at the end of one of these things, but having been in this business from the beginning of the AIDS epidemic to now, I'm going to tell you what I think. I think that everybody at this table should be proud to be in a profession, whether on the financial side or the medical side, in which we've gotten to this spot. I look back over 30 years of triumph. We are here. We are arguing over dollars and cents as opposed to funeral costs. And when I think back as to how I've spent my life in this profession with people such as you, all of whom I admire, I just think that's been the best 30 years of my life, and it's wonderful, and I look forward to more. This is remarkable stuff. And everybody out there in this business, you can give yourself a round of applause too. All of us have been part of this journey, which is insanely great. This is just one example of it, but it's a heck of a great one. And with that, I want to thank all of you for your contributions. And I want to thank you, of course, for joining us out there. I hope you found this AJMC Peer Exchange to be informative. I'm Dr. Peter Salgo. I'll see you next time.